Okay, so welcome to this next video in which we are discussing heart failure and heart failure medications. Okay, so in this video what we're now going to turn our attention onto is heart failure medications. Okay, so drugs that are used to treat heart failure. Okay, now most of these drugs work by stopping the neurohormonal mechanisms, because remember, the neurohormonal mechanisms are what drive this progression of the failure of the heart. Okay, they make the heart weaker in the long run by driving the hypertrophy. Okay, so if we could stop the neurohormonal mechanisms, or at least reduce them, because we're not going to be able to completely stop them, okay, but if we can reduce them, then we can reduce the rate at which hypertrophy is going to occur, and therefore we can reduce the rate at which you're going to progress into heart failure, and therefore hopefully extend your life. Okay, so most of these medications then are going to work by blocking neurohormonal mechanisms. So let's now talk about these. So the first ones that I want to talk about are the ACE inhibitors. Okay, drugs which are going to inhibit the angiotensin converting enzyme and are therefore going to turn off the angiotensin system, the renin-angiotensin-aldosterone system. Okay, so let me give you some examples of ACE inhibitors, and then we'll look at what the effect of them is going to be. Okay, so ACE inhibitors all end in the suffix pril, basically. Okay, so we've got enalapril is a good example, captopril is another example, and then ramipril is another example. Okay, so they all end with this four-letter suffix, which is pril, ramipril. Okay, so these are all very famous drugs, so you can recognize ACE inhibitors nice and easily by the suffix pril. Okay, so what then is going to be the effect of these drugs? Well, let's bring up our piece of paper in which we have discussed the renin-angiotensin-aldosterone system. Okay, so here it is. So remember, angiotensin converting enzyme is this enzyme that's attached to the luminal aspect of the endothelial cells all over the body. Okay, so if we give these drugs, they are going to inhibit that enzyme, and they're going to inhibit the conversion of angiotensin I into angiotensin II. Okay, so basically what you're going to do is you're going to stop the formation of angiotensin II. You're going to lower the amount of angiotensin II within the blood. Okay, so what's the effects of this? Well, let's think about what the effects of angiotensin II was. Angiotensin II worked on the angiotensin II subtype 1 receptor. That's the main receptor for angiotensin II. Okay, and it caused, firstly, arterial constriction. Okay, so it caused contraction of the smooth muscle cells in the walls of the large arteries, so including the aorta and other big arteries, and that raised mean arterial blood pressure. Okay, and it was one of the factors that helped to bring mean arterial pressure back up. Okay, so if we now give an angiotensin converting enzyme inhibitor, such as one of these three drugs that we've just talked about, that's going to help to bring down mean arterial pressure. Okay, now not only is that going to help us to raise the stroke volume of the heart, because now the left ventricle will have to be pumping against a lower mean arterial pressure, so it will be able to eject a greater amount of blood, but also that's going to help to prevent the hypertrophy, because remember, now we're going to reduce that pressure overload. Okay, so when you had a very high arterial blood pressure, then that damaged the heart, remember, because you had to get the pressure in the left ventricle up to that same pressure before blood could eject out of the left ventricle into the arterial system. Okay, and when you have to build up to that huge pressure in the left ventricle, that's going to be sensed by receptors in the cardiomyocytes, and that's one of the driving factors for hypertrophy. Okay, so now pressure overload induced hypertrophy is going to be reduced. Okay. In addition, what's it going to do? It's going to mean that we're now not going to be stimulating the zona glomerulosa cells to release as much aldosterone. So aldosterone is also going to go down. So you're effectively switching off the renin-angiotensin-aldosterone system. You're switching off the aldosterone now. Okay, that means that you're going to retain less fluid and salt. Okay, so blood volume is then going to go down. Now, what's the advantage of reducing blood volume? Well, that means that the pressure in the central venous system, so central venous pressure, and the pressure in the pulmonary venous system are going to go down, because remember, when you increase blood volume, really what you do is you increase the volume in the venous systems rather than the arterial systems. Okay, so by reducing blood volume, by stopping the chronic production of aldosterone by the zona glomerulosa cells, you're going to reduce the central venous pressure and the pulmonary venous pressure. Okay, now what's the effect of that? Well, remember, these drive the stretching of the ventricles, the right ventricle in the case of the central venous pressure and the left ventricle in the case of the pulmonary venous pressure, which then fills the heart up further to the full end diastolic volume. Okay, so if you now reduce these, that's going to mean that the end diastolic volumes in both the ventricles are going to be reduced. Now, of course, that is going to compromise stroke volume slightly, but remember, there was something more dangerous here. Because if you have chronically elevated end diastolic volumes in your ventricles, that's one of the leading causes of the hypertrophy. Okay, remember that was called volume overload, and it was capable of inducing hypertrophy within the cardiomyocytes by receptors that are not understood. Okay, so the pathways by which pressure overload and volume overload actually lead to cardiomyocyte hypertrophy are not understood, but we are confident that they exist. Okay, so by reducing mean arterial pressure and reducing central venous pressure and pulmonary venous pressure, you have already reduced two of the factors which drive hypertrophy. In addition, remember that the angiotensin II itself was actually one of the key stimulators of hypertrophy directly. Okay, so the cardiomyocytes had angiotensin II subtype 1 receptors on their surface, okay, and the angiotensin II was acting on that, and that was one of the things believed to lead to downstream pathways which begin the hypertrophy process. Okay, so by reducing the level of angiotensin II with these angiotensin converting enzyme inhibitors, we're going to reduce hypertrophy in that way as well. So we have reduced three of the things which are going to be driving the hypertrophy of the cardiomyocytes, which is a good thing. Okay, right, so those are the ACE inhibitors. Very much so related to the ACE inhibitors are the angiotensin receptor blockers. Okay, so basically these are going to also turn off the effects of angiotensin II, but in a different way. So the ARBs, these are called, and this stands for the angiotensin, that's the A, okay, and then the R is for receptor, and then the B is for blockers. Okay, so angiotensin receptor blockers. Now these are basically competitive antagonists, oops, not blocks, blockers. These are effectively competitive antagonists for angiotensin II receptor subtype 1s. Okay, and the most famous example of an angiotensin receptor blocker is losartan. Okay, again, these drugs can be recognized by a suffix. Okay, they all have the suffix zartan. Okay, so you can recognize them by that. So losartan is one of the most famous examples of an angiotensin receptor blocker. And basically what it's going to do is, if I just draw a picture of the angiotensin II receptor 1, okay, remember it's a G protein coupled receptor. Basically, these drugs are competitive antagonists at this receptor, so they will bind to the angiotensin II receptor 1, and they will stop angiotensin II from being able to bind there. So this is our drug here in green, okay? And by binding to the angiotensin II receptor subtype 1, you're going to not stimulate the receptor. That's the important thing about an antagonist. It doesn't stimulate the receptor, but it blocks the agonist, which in this case is angiotensin II, from being able to bind. So a competitive antagonist is just something that binds in the agonist binding site and does not stimulate the receptor. Okay, so it just blocks the angiotensin II from activating the receptor. Okay, so again, this is going to do effectively the same things as the ACE inhibitors, but by a different mechanism. So you are going to get the production of angiotensin II if you give one of these drugs. It's just it's not going to actually be able to have any effect. So it's not going to be able to stimulate the smooth muscle cells of the arteries to contract, and therefore mean arterial pressure is going to go down if you give one of these drugs. In addition, it's not going to be able to stimulate the zona glomerulosa cells to release aldosterone, and therefore aldosterone is still going to go down, and therefore central venous pressure and pulmonary venous pressure are going to go down because of the reduction in blood volume. Okay. In addition, although there is still going to be angiotensin II, it's not going to anymore be able to act on the cardiomyocytes, because remember, it acted on the cardiomyocytes via the angiotensin II receptor subtype 1, which we have now blocked using our angiotensin receptor blocker. Okay, so again, you're going to reduce that direct stimulation onto the cardiomyocytes by the angiotensin II, which is going to help reduce the hypertrophy as well. So it's going to do effectively all the same things as the ACE inhibitors, but working slightly more downstream than the ACE inhibitors. Okay, right. The next class of drugs that I want to talk about are the beta blockers, okay, which are going to help to reduce sympathetic stimulation on the heart. So beta blockers. Now, a specific beta blocker that is very useful in heart failure because of its lack of selectivity is carvedilol. Okay, so carvedilol is actually a non-selective beta blocker, which means that it's a competitive antagonist for beta 1 receptors and beta 2 receptors, but more than that, it's not just a non-selective beta blocker, but it's actually also an antagonist for alpha 1 receptors, and you can hopefully see why that is going to be a very, very useful drug to give in heart failure. Okay, so usually you want selective drugs. You want drugs to be selective for a specific type of receptor. So you have the non-selective beta blockers which block beta 1 and beta 2, and then you have selective ones which just either block beta 1 or beta 2. Carvedilol is not one of those drugs. It blocks beta 1, beta 2 and alpha 1. However, it's very, very useful in heart failure because remember, those were the 3 types of receptors that you had on cardiomyocytes. Okay, yes, the beta 1 was the most important for the physiological function of acute sympathetic stimulation on cardiomyocytes, but as far as inducing hypertrophy in cardiomyocytes is concerned, all 3 of these are involved, beta 1, beta 2, and alpha 1. Okay, so adrenaline and noradrenaline stimulate these receptors on the surface of the cardiomyocytes, and that triggers hypertrophy. Okay, it's one of the key things that triggers hypertrophy. So carvedilol, through blocking the chronic sympathetic stimulation, is going to help to reduce the hypertrophy. So sympathetic stimulation on the heart has gone down, and that's one of the other things that stimulates hypertrophy. In addition, of course, this beta blocker is also going to help to reduce other effects of the sympathetic nervous system. So if I get my picture of the sympathetic nervous system back up, remember, the sympathetic nervous system had other effects other than just on the heart. It also acted on alpha 1 adrenoreceptors on smooth muscle cells of arterioles going to places like the gastrointestinal tract and caused them to contract. That increased total peripheral resistance and therefore increased mean arterial pressure. So, if we're giving a drug that blocks alpha 1 adrenoreceptors, which carvedilol does, then we'll block that. Okay, so we will help to reduce mean arterial pressure again. Okay, so I'll just add that on here. So we'll help to reduce mean arterial pressure, and again that will help to reduce pressure overload on the cardiomyocytes, which is another one of these driving forces for hypertrophy. Okay. In addition, remember, the sympathetic nervous system stimulated the renin-angiotensin-aldosterone system by beta 1 receptors. So if we're blocking beta 1 receptors, then we're going to block the activation of the renin-angiotensin-aldosterone system. So all the benefits that we've seen with ACE inhibitors and angiotensin receptor blockers are also going to be there for this drug carvedilol, or other beta blockers as well. So carvedilol is a very useful drug in heart failure, but other beta blockers can be used as well. Okay, that one is a particularly special one because it also blocks alpha 1 receptors, which is useful in the case of heart failure. Okay, right. Now, all those classes of drugs, ACE inhibitors, angiotensin receptor blockers, and beta blockers, they all work by blocking the neurohormonal mechanisms. The final class of drugs that I want to discuss is actually going to work by increasing the strength of the heart okay, increasing the strength with which cardiomyocytes are capable of contracting. Okay, and this final class of drugs is what's known as the cardiac glycosides. Okay, so cardiac glycosides. And these are actually going to work to increase the force with which cardiomyocytes can contract by increasing the amount of calcium stored in the sarcoplasmic reticulum. Okay, so remember, the entire problem with hypertrophied cardiomyocytes is that they had less calcium in their sarcoplasmic reticulum. These cardiac glycosides are going to help to reverse that. They're going to help to bring back up the amount of calcium in the sarcoplasmic reticulum. And that's how they're going to make the cardiomyocytes contract harder, by increasing the size of the calcium spikes. Okay, so the key example of a cardiac glycoside that is actually used clinically is digoxin. Okay, however, there is another cardiac glycoside that I can't really not mention, okay, because it's an incredibly famous drug. It's not really used clinically, but it's still incredibly important experimentally, and that's ouabaine. Okay, spelt in this ridiculous way. So O-U-A Bain, but it's pronounced ouabaine, as though there's a W at the front. Okay, so these are the two key examples of cardiac glycosides. Digoxin is the one that is actually clinically used. Ouabaine is a very important drug experimentally, and it's just a good thing to know about. Okay, now, they both do the same thing, which is that they block the activity of the sodium-potassium ATPase. Okay, so let me put this here. So, this is a new player that we haven't seen before, but we have seen its importance before in this video. So the sodium-potassium ATPase. Okay, so this is a protein that you're going to find in all sorts of cells, but for our purposes we're interested in its presence within the cardiomyocytes, and it's going to be on the sarcolemma of the cardiomyocytes, so on the cell membrane. Okay, now what does it do? Well, it's a primary active transporter. It throws 3 sodium ions out of the cell and brings 2 potassium ions into the cell. And every time it does that, it hydrolyzes a molecule of ATP down to adenosine diphosphate, ADP, and inorganic phosphate. Okay, right. Now, it is incredibly important in maintaining the concentration gradients of sodium and potassium across the cell membrane. So remember, we said earlier on that the sodium concentration gradient across the cell membrane was 145 millimolar extracellularly and around 12 millimolar intracellularly. Okay, now, that concentration gradient was important for something. Okay, that was important for our sodium-calcium exchanger. Okay, which was one of our key homeostatic mechanisms for controlling cytoplasmic calcium concentration. Okay, so remember, the sodium-calcium exchanger allowed one sodium to come in and threw a calcium ion out. Okay, and was an example of a secondary active transporter because it used the energy released by the sodium coming in to move the calcium out. Okay, so the cardiac glycosides then, these bind to the extracellular aspect of the sodium-potassium ATPase and stop it from functioning. Okay, now, let me stress something. When you give these drugs for heart failure, and the only one you'd give would be digoxin, you give it in a low enough dose that it is not going to block all of the sodium-potassium ATPases. If you gave it in a dose where it actually blocked all the sodium-potassium ATPases, you would kill the person. Okay, you give it in a very low dose so that only some of the sodium-potassium ATPases are actually going to be blocked. So you're only actually going to reduce the function of all of the sodium-potassium ATPases, okay, because only some of them are actually going to have their activity blocked at any one time. You are not going to give it in a dose where all of the sodium-potassium ATPases are going to be blocked, okay, because that would be fatal. Okay, so what you do is you reduce the activity of sodium-potassium ATPases in the entire sarcolemma. So a fraction of the sodium-potassium ATPases have now got this drug bound to them and are no longer functional. What that is going to mean is that you do overall reduce the sodium gradient across the cell, so the sodium concentration gradient is going to be reduced. Okay, and that means that the activity of the sodium-calcium exchangers here, so this is the sodium calcium exchanger 1, the activity of this is going to be reduced, because if the sodium gradient's gone down, then its activity is going to be reduced because its activity is completely and utterly determined by the sodium gradient. Okay, so if you reduce the activity of the sodium-calcium exchanges, what effect is that going to have on that equilibrium of calcium moving across the cell membrane? Well, let me just get the picture back again. Here is our picture where we drew the equilibrium. Remember, the amount of calcium leaking in is going to be in equilibrium with the amount being moved out. We have suddenly reduced the amount that's going to be moved out. So now the amount that leaks in is going to beat that. So what you're going to do is you're going to shift the equilibrium. Calcium is going to move into the cytoplasm of the cell, and that's going to cause calcium concentration in the cytoplasm of the cell to raise a little bit. It's going to rise, okay, until the point that the amount of activity by the sodium-calcium exchanges in the PMCA is now going to be increased enough again that it will be balanced with the leak, basically, because obviously if you increase the amount of calcium in the cytoplasm, that's also a substrate for the NCX and also the PMCA, so that's going to increase both of their activities. Okay, so the overall result of reducing the function of the NCXs is that you increase the calcium concentration slightly in the cytoplasm of the cell. Now, what effect does that then have on the sarcoplasmic reticulum? Well, if you increase the concentration of calcium in the cytoplasm of the cell, that's going to increase the function of the SERCA2s, because now they've got more calcium to work with. Calcium will bind to them more often if the calcium concentration is higher in the cytoplasm. So SERCA2As are now going to pump more calcium into the sarcoplasmic reticulum lumen, and that's going to shift the equilibrium of calcium in the sarcoplasmic reticulum. Okay, because initially what will happen is you're bringing more calcium in, and you're still releasing the same amount of calcium because the calcium concentration in the sarcoplasmic reticulum lumen hasn't changed yet. That will then mean that there's a net movement inwards, so now what will happen is the calcium concentration in the lumen will go up, okay, until the point where the leak out is now big enough to completely match the amount that you're bringing in at this increased rate due to the increased cytoplasmic calcium concentration. So, the effect here of the cardiac glycosides is to increase cytoplasmic calcium concentration by a little bit, by only a tiny bit, but that has a big effect on the sarcoplasmic reticulum calcium concentration because it reshifts the equilibrium. So sarcoplasmic reticulum calcium concentration is going to go up, and that then means that when you excite the cardiomyocyte and you get the calcium spike, more calcium is now going to be released from the sarcoplasmic reticulum, and you're going to generate a larger calcium spike, which is then going to cause a greater force of contraction. Okay, so that's how cardiac glycosides increase the force of contraction of cardiomyocytes, by shifting this equilibrium and raising the calcium concentration in the sarcoplasmic reticulum lumen. Okay, so that now finishes our discussion of heart failure and heart failure medications.